Health Affairs, Alan Weil was Executive Director of the National Academy for State Health Policy and the Director of the Urban Institute Assessing the New Federalism Project, one of the largest privately funded social policy research projects ever undertaken in the U.S. He is a member of the Kaiser Commission on Medicaid and the Uninsured, and on the Board of Trustees of the Consumer Health Foundation, Washington, D.C. Many of you know Alan from his time as Executive Director of the Colorado Department of Healthcare Policy and Financing. Please welcome our friend Alan.
Thank you, Ron, and thank you all. Good morning. Ron, you remind us that connections are the most important element of health, and it's a great way to kick off today where we're going to focus on connecting communities to well-being. It's always a pleasure for me to be back in Colorado and a pleasure to be back at the symposium. We do have seats up front for those of you who are looking for a place to sit. It's always safe to assume that the front rows are empty, so please come on up and join us. My topic to get the various speakers for today started is connecting communities to well-being. That's what we're going to focus on today. Now that I've become editor of Health Affairs, I think a little bit differently. I think in word counts, because that defines how much space an article will take up. And so what I decided to call my presentation was Past, Present, and Future in 5,000 words. And since you all know that a picture is worth 1,000 words, right? So I figured I'd do this in 5 pictures. I basically have given up PowerPoint, but was told, you know, come on, give us a few pictures. So I'm taking the term pictures quite loosely, but this is more of a talk than a PowerPoint presentation. Let's start with an acknowledgement that in an event like this and a desire to focus on connection, that it's really, we're at a wonderful place in healthcare right now. We've come to understand the importance of social context for people's well-being. Basically, you just can't pick up an issue of health affairs or anything else without seeing people make reference to the importance of looking beyond the office visit, the hospital walls, to understand what makes people healthy. And so I just sort of picked at random this quotation: steady employment, fair wages, proper housing will prevent more disease than most laboratory research and education about disease prevention. We get it now. We finally understand that this context is really what determines people's health. So we're at a new point of revelation in healthcare. Who do you think said this? Any ideas? Well, it's not really a fair test. But since I know we have a very social media savvy audience, this is really a TBT for those of you in the Twitterverse. This is not something from the current issue of Health Affairs. This was actually written by Ernst Boas in 1940. When he was writing about the growing scourge of chronic disease. And it's just a reminder that we have not just for the first time come to understand the connection between community well-being and individual health. In fact, I would argue that we always understood it, and what we've gone through is a period of forgetting. And now it's time for us to remember what we always knew. Healthcare didn't used to be separate from communities. People were born at home, and it wasn't viewed as a medical phenomenon. Death was not viewed as something to be delayed and deferred as long as possible. Hospitals were created to give people a place to die if they couldn't die at home. We viewed health as something that happened in the home and the community. And health care started taking us away from that conception. And it did it for some good reasons. This is not to criticize the evolution, but if we think about why is it that we started separating health care from conceptions of well-being and community, it was partly because health care started actually mattering, that treatments were effective, they were prolonging people's lives. We went through an era of professionalism, the Flexner Report in the early 1900s. We also saw other professions arise, the profession of social work. And as you become professionalized, you start creating boundaries. That's one of the definitions of a profession, is to put walls around you. You have your own language. And of course, as we started curing, we also found that access to care was important, and we developed these concepts of insurance. And once you have insurance, well, insurance pays for something. How do you define what the something is? It's an intervention, it's a treatment, it's an interaction with a system. And so you start defining this system, and the system takes on its own identity separate from the broader concepts of community. So we've always thought of well-being as something rooted in the community, but it's the rise of health care as a separate entity that started pushing us away. I had an experience that I think captures quite nicely this change in thinking. It's not quite as engaging a story as Ron's, but I will tell it nonetheless. There used to be in Colorado something called the Department of Social Services. And in July 1st of 1994, so 21 years ago, we divided it in half. We created the Department of Human Services and the Department of Healthcare Policy and Financing, and I became the first director of what we all know and love as HCPF. Why did we do this? Because we thought that health was different from all those other social services. We needed to act differently. We weren't part of the welfare system, the social welfare system. We were purchasing for value. We needed a different interaction with those who were delivering services than those who were providing child care or providing employment services to people who needed jobs. And of course, when HCPF was separated out from DSS, Medicaid was bigger than the entire social services department other than Medicaid combined. So we were bigger, and we had a different scale. But there was a lot of complexity around the division, and much of that complexity had to do with the fact that the counties still had social services departments, and to apply for assistance, you still walked into a county department. And at that level, at the local level, at the community level, these systems were together, but at the state level, at the operational level, they were divided. As we worked on improving our eligibility systems and improving the relationship between the new Department of Human Services and Healthcare Policy and Financing, we had to figure out a challenge that exists to this day, which is, on the one hand, we as the healthcare agency wanted to make sure that everyone who needed help with healthcare could get it. And now with the Affordable Care Act, of course, assistance purchasing health insurance goes way up the income scale past median income. And yet most social services programs are focused on the lowest income, whether we're talking about housing or food stamps or cash assistance or employment assistance and the like. And so we built separate eligibility systems because our conceptions of these programs are rooted in who's deserving. And because healthcare is more expensive, more people deserve assistance in that area. So we built bureaucratic barriers to people connecting with the services they needed because we had to differentiate across people in who deserved assistance. And of course, Medicaid is an entitlement. By which means quite a few things, but in this context I mean that there's an open-ended draw on the federal treasury. Whatever the state spends to provide medical assistance, the federal government will match. The other programs, welfare used to be, with welfare reform, it is no longer. Child care assistance certainly isn't. Housing assistance certainly isn't. So many of the other forms of support we provide families are not entitlements. And so just as we pulled healthcare services out of the community and disconnected the healthcare system from the community. In the public sector, we did the exact same thing. We took healthcare programs, we pulled them out of the social context in which people live, we pulled them out operationally from the agencies that interact with people, and we said, we're going to do health over here, and we're going to do social services over there. And so what I want you to take away from this is that the disconnect, as we look at the title today of Connecting Communities and to Well-Being, the disconnect is a disconnect of our own creation. This is not inherent. It is not inherent that health and social, or health and employment, or health and housing, or health and family support, there's nothing inherent about those being separated. What's inherent is about them being together. Their distinction and differentiation is something we created. And now it's our job to understand the mistake we made for good reasons and undo it so we can get the benefits of the connections that we all know we needed. At the time, we thought this change was progress. Now I would say it was only progress at the time, but it's time to rethink, not the organizational structure. I'm not here to tell you to recombine human services. HCPF, God knows that's a more complex topic. But the division within state government and the way of thinking at the time had good motivation, and already we see increased work between these departments and others. Now, I know I wasn't here yesterday, I was in transit, but I have some sense of what was discussed, and you heard a lot about what's happening in the healthcare sector now to try to undo this problem. Payment reform, different models of care, accountable care organizations, reaching back out into communities to undo the separation that we created so many years ago. And I gather that there was a lot of enthusiasm and some really interesting ideas presented yesterday. And I want to align myself with them, but I want, as we talk today about connecting communities, to also offer some cautions that hopefully you can also keep in mind as you think about that transformation. So I want to offer to you Weil's postulate. So my postulate is that population health is not the same as the sum from 1 to infinity of accountable care organizations. I love accountable care organizations. I hope someday to be served by one. I have no doubt that I will be. But I do not believe that a bunch of ACOs is the same as attending to the population's health. And I know you're going to hear more about this today. I want to take this on in two different ways. I think it's conceptually inaccurate to think of population health as being the result of the proliferation of ACOs. And I think it's practically a stretch to think that ACOs will get us there. And this is not to say that I'm against what folks doing ACOs are trying to do. I just want to put it in some context. Why do I think it's conceptually wrong to think of ACOs as the way to promote population health? Well, fundamentally, I go back to where I started, is that it puts health squarely in the frame of being a medical phenomenon. So ACOs are run by medical providers, doctors and hospitals, who provide medical services, and they provide clinical care. But if we want health, and you saw the slide yesterday, we know that health does not arise primarily from medical interventions, although they can be critical when you need them. So conceptually, health is not primarily the result of medical phenomena. So if medical providers are in charge of giving us health, population health, not clinical improvement, we're conceptually, I think, in the wrong starting place. This is more of an ideological statement on my part. I've never been shy about this, but I think a second conceptual problem, is that it privatizes the concept of population health. From my perspective, population health, community health, is a social phenomenon. It's a community phenomenon. An ACO is a private entity. Whether it is run by a for-profit, not-for-profit, that's not the question or the issue that I have. It still is a private entity. And what happens when you are an ACO tasked with improving population health? You invest in various types of infrastructure to improve the health not of the population, but of your panel, or the people for whom you are financially responsible. And so investments in their health reside within your organization, not within the community. I know Neil will talk more about this. I don't want to, he's given it more thought than I have. I don't want to push this too far. But I just want to give you a quick story. I serve on the board of a foundation in the Washington, D.C. area, and we were talking about community health workers. And one of my colleagues on the board works for a health system in the DC area, and they're hiring up community health workers as fast as they can. Why? Because they want to reduce their readmission rates, because they're getting financially penalized at the hospital if they're too high. So the community health workers aren't working in the community, they're working in the hospital. That's not a community health worker anymore. That's a hospital worker. So this notion of building the community infrastructure into the ACO is a privatization. I'm not anti-privatization as a theoretical matter, but I think in this instance it undoes the gains that we're trying to build at the community level. And fundamentally, and I could go on much longer than you would want me to on this last conceptual concern, we know that the quality metrics we use for accountability are rudimentary. We're working on them, we're improving them, there's a lot of controversy over them. But fundamentally, when ACOs talk, they talk about the financial incentives to maintain the health of the people they serve and the investments they are making and want to make in order to do that. And so the primary leverage point that we have with ACOs is dollars, and dollars certainly speak. But if we are talking about population health is multidimensional. And so thinking of ACOs as the way to achieve population health converts a phenomenally complex, multidimensional phenomenon, health and well-being, into a unidimensional metric, money. And I think conceptually that's a problem. So don't get me wrong, I would rather hospitals think about how to keep people out of the hospital than get them in. I would rather they invest in community resources than not. But do I think that a bunch of ACOs are going to give us what we think of as population health? I think conceptually it's the wrong approach. I also think there are huge practical impediments to ACOs and payment reform around population health getting us where we want to be. These are just simple numbers from the Bureau of Labor Statistics with all of the limitations that any BLS numbers would have. There's a lot of variance around these numbers. I am not trying to make a political statement. But this is what we pay various participants in the healthcare sector. So why is this relevant to thinking about how we pay accountable organizations to improve health? First of all, the existing institutions that we turn to invest in population health are very constrained in their ability to reallocate resources to where they would have the greatest effect on actual real people's health, community health, population health. If you have a building and a bond that you have to pay off because you sold the bonds to build the building, you still need the revenue stream. If in order to hire a neurosurgeon, and if we'd put neuro before surgeon here, the numbers on the right the number on the right, as I'm sure you know, would have been a lot larger. You have to pay the prevailing rate for that surgeon. even if from a population health perspective, you might find that the community benefits from hiring a few more community health workers. Organizations, large, complex, well-resourced organizations, getting payments for performance and being given the task of reallocating them to improve the health of the community are tightly constrained in their ability to change where the money goes. They can move dollars on the margin. They can get a truck and a mobile van and send it out in the community and do blood pressure testing. That they can afford. Can they fundamentally reallocate resources to where they maximize population health? I don't think they can, and we all have boards. I don't think their boards will let them. So practically, there are huge constraints in this kind of re-engineering. There's also a lot of discussion, and I'm happy to hear it, about partnerships. Well, we're going to partner with the Community Mental Health Center. We're going to partner with the food bank. We're going to partner with the Meals on Wheels because we know that we need them in order to improve health. And that's our mission, and that's what we're being paid for. Am I glad that these entities are reaching out to form partnerships? Yes. Are these partnerships the way I would define partnerships? When one partner gets the money, has the lawyers, and has the infrastructure, and the other is a community-based organization with a volunteer board and very limited financial sophistication to negotiate its role in this 1/6 of our economy ecosystem that they have thus far kept themselves out of. I'm skeptical about whether the terms in which that engagement are going to be made are going to feel in the end like what I think of as partnership. This is the haves reaching out to the have-nots and saying, we need you. And I'd rather they do that than sit behind the wall and say, we don't care about you. But to think that somehow this is community-based, organic source of improvement of the population's health, I don't think so. And I will just, as an aside, say, at some, risk of pissing you all off, but so it goes. I sit on the board of the Community Health Foundation in the Washington, D.C. area, and when we talk about what it would take in the community to improve health, yeah, we talk certainly about jobs. We talk about housing. Sometimes we talk about education. But we talk about things like racism, institutional racism, structural class disparities. And I don't hear those conversations at health conferences where people are talking about payment reform and relying upon accountable care models. So, wow, I guess I didn't piss you off. Well, those of you I pissed off, you didn't applaud. That's fine. It's like, when the president speaks at the State of the Union, one side of the aisle applauds, the other is just stoic. But the point is simply that we are giving, as we embrace the model of accountable care, we are giving inherently conservative, well-resourced institutions the responsibility for transformation. And well-resourced conservative institutions don't typically go out and do particularly dramatic, radical things. And so we should be realistic about the likely endpoint of this process. Is it potential that there will be improvement? Absolutely. Do we need improvement? Absolutely. Let's just be realistic. And which brings me to the final practical challenge that I think confronts us as we think about these alternative models, which is we love talking about paying for value. We'd all rather, we want to pay for value, not volume, right? It's like managed care. What do you want? Unmanaged care? So yes, of course we want to pay for value. What we don't have is a very clear model for how to pay for and generate improvement. And we see this playing out again when we look at all the financial penalties and incentives for high quality, which is that if you take an underperforming institution and you put in a pay-for-performance model, the underperforming institutions lose resources and therefore are less likely to improve their performance because they now don't have the resources to do any improvement. The best performing have additional resources because they are performing well, and lo and behold, you can see a separation. Now, there are ways to overcome that. You can pay for improvement as well as for performance. That gets complicated. Where's the infrastructure to help those who are trying to improve? There was a big hurrah when the sustainable growth rate formula was eliminated within Medicare and replaced with a value formula for paying physicians. Everyone was happy to see it gone because everyone hated the SGR, but we don't really have any idea whether the new value metrics that are going to be used in Medicare are actually going to do any good, whether or not they will yield quality improvements, which after all you would think would be the purpose. And so we love talking about value, and we certainly would rather pay for value instead of paying for volume, but we don't really have clear models for how to do that in a way that yields improvement, which after all should be our purpose. So I'm going to say for the 10th time, I am not opposed to shifting our payment models from volume to value. I am not opposed to the creation of accountable care entities and capitating and putting the health system at risk for improving outcomes as opposed to simply providing medical services. I just think we have to be realistic about what that framework what platform the framework stands on conceptually and what some of the practical barriers are to achieving it. So my fifth picture, and it really is the only picture, and it really is worth 1,000 words, we released this just yesterday, which is why I wasn't here yesterday. The actuaries at the Centers for Medicare and Medicaid Services every year produce their projections for future healthcare spending. And just yesterday they announced that in 2013, the last year for which we have actual data, you can see at the top that 17.4% of our GDP was spent on health. In 2024, 10 years from now, it's projected to just sneak up against 20%, which would, of course, be a fifth of our economy. On the bottom, you can see the bars, which show you growth in national health expenditures versus growth in GDP. As long as that blue curve is above the red curve, our share of GDP devoted to health is increasing. And you can see that basically that's always the case. Now, the good news, it's easy to get scared. I mean, we were scared when national health expenditures hit 8% of GDP, and we were terrified when it hit 12, and when it hit 15, the sky was going to fall, and here we are at 17. Do remember that even if it's hit 20, there's still a whole lot of other money in the United States economy to help us buy iPhones and come to Keystone and the like. So don't worry. There's no magic number or share that national health expenditures should be. But the title of my remarks was Past, Present, Future, and the future question I want to leave you with is whether this is where we want to go, because this is what the actuaries tell us is where we're going to go based on their best sense of where things are. Now, I won't steal Neil's thunder, but I hear that yesterday you heard about Health 2.0. Today you're going to hear about Health 3.0. It's just proof that things move really fast in healthcare. We created this division between communities and healthcare. And my hypothesis, my argument to you, is that I would rather not have us on this trajectory, just because I think in terms of happiness, we could happily spend those resources in other places and be better for it. That's my sense. But the only way we change the trajectory is to decide that this is not the one that we want. And because it's today's title, I will embrace the notion that really fundamentally what it will take to get us off of this upward trajectory is not a bunch of ACOs, they may help, but to reconnect communities to well-being. In fact, I would argue that instead of thinking of today's session as connecting communities to well-being and the solution to the problem posed by this chart as being connecting communities to well-being, it's acknowledging and embracing the notion that communities are the root of well-being. And health and healthcare services are in service of the well-being of communities. And if we can have that as our mantra, then we can have health, we can have well-being, and maybe we can have a few more dollars to come and spend in Keystone. Thank you very much.